as we move on into the field of liver, we talked yesterday about an introduction and some of the reasons the liver can cause certain problems when it's diseased, and some tests to try to identify that liver disease is present. So the rest of the lectures today and tomorrow and one or two next week are really going to have to do with either the liver diseases that can occur or the consequences of them. And so what I'm going to talk to you about today is an introduction to some aspects of hepatocellular diseases. I'm going to talk about how to identify viral hepatitises. Anna Locke, who's really an internationally known expert on viral hepatitis, will give you a talk next week that has more specifics on the individual viruses and some of their peculiarities. I know it's going back to infectious disease again, but it's a ubiquitous problem. So what we want to learn to do is, we've already talked a little bit about identifying the hepatocellular versus the cholestatic diseases. And so hepatocellular diseases are ones where the primary and originating injury is to the hepatocytes. They're being injured, they necrose, they apoptose, etc. If you destroy enough hepatocytes or you don't perfuse them, then you'll have decreased synthesis, decreased metabolic activity. Those are the functional components. And the sign is the release of these intracellular contents that we can measure as the AST and the ALT. Cholestatic diseases are diseases where the primary problem is impairment of bile formation or bile flow. So that can be a problem at the level of the liver cells, but we're talking diseases where this is really the major problem of the liver, not that the cells are being necrosed. Or you can have problems with the bile ducts all the way out of the liver where there's a blockage or an impairment of the flow of bile. So you get substances excreted in bile that build up in blood, and bilirubin is the one that's the easiest to measure. And this is where the alkaline phosphatase tends to go up as the predominant abnormality. We also have temporal aspects of liver diseases. There's acute diseases that generally came on within the last few days or weeks. They may last up to a month or two, but then if they're acute resolving, they then go away. And you can have injury to the hepatocytes or injury to the bile duct cells. Chronic liver diseases means you have injury, either hepatocytes or bile ducts or both, that goes on for months to years. And at that point, you get additional problems. You get an injury repair cycle that can lead to scar tissue or fibrosis and cirrhosis. And by the time somebody comes in with a very cirrhotic end-stage liver, it may not be as obvious what the original disease was. And Joel Greenson will be spending a lot of time later this morning telling you how to make a good liver bad. So we have to think of, we may be seeing people who come in with an acute new liver disease. We may see people coming in who weren't aware they had liver disease. They're coming in at a chronic stage, and they have some of these aspects going on as well. So we've talked about how to identify which category so you can limit the number of diagnoses you have to think about. Cholestatic, the problem is bile flow of the biliary tree, and alkaline phosphatase is the main indicator. Hepatocellular is the release of these enzymes. And some of these other things can be useful in terms of saying how badly has the liver function been impaired. So hepatocellular diseases, often the term that's used is hepatitis. We have to define for our patients that that's really a non-specific term. It means liver inflammation. But they're diseases that predominantly affect the hepatocytes, and we've talked about the transaminases. So this is a normal liver. You have nice, normal columns of nice, fat, pink hepatocytes with sinusoids in between. I think there's a Kupffer cell sitting there. You have this small portal tract. It's got a few lymphocytes in it. It's got some portal veins. It's got a little artery. It's got a nice little bile duct here with the cuboidal epithelium. Looks very nice and quiet. This is a liver with a hepatitis. That means there are a lot of inflammatory cells in there. So here's a portal tract. This is the portal vein. and you just see sheets of these blue nuclei. These are primarily lymphocytes in the portal tract. And although you see nice hepatocytes out here, you're seeing inflammatory cells percolating out into the parenchyma, sometimes surrounding groups of hepatocytes. And so this is a nice, brisk hepatitis. Don't know the etiology, but we know there's hepatocellular injury. So this is a case where you'd expect the AST and the ALT to be elevated to at least some degree. So the aspects of hepatocellular disease you need to think about is how, aside from what's the name of the disease, is what's the severity? How bad is the necrosis and damage that's going on? And is it going on at a rapid rate and may destroy the whole liver in a brief period of time, or is it slow and steady? How much liver function is left? You can also assess the clinical symptoms. How sick are people? The time course, is this acute or chronic? And then you want to determine the etiology so that you can see if there are treatments available, predict the natural history, things like that. So how do the extent of liver cell necrosis? That's the transaminases, which we talked about. And what they're telling you is the rate of death of hepatocytes. Enzyme clearance is pretty stable, and most of them are cleared in a day or so. So that's why this is an acute snapshot of injury. How do you tell dysfunction? Well, that is the number of functional hepatocytes that are left, and it depends on how many cells are sick, how fast they're dying, how long this continued killing of hepatocytes has been going on, and how fast the liver is regenerating. And unfortunately, we don't have good ways to quantitate many of these things, but it's a way of thinking about the evolution of a disease. How to assess impaired liver function? Protein synthetic function is the easiest and usually the most reliable. Increased prothrombin time, low albumin. Assessing organic anion transport is a little tougher because, of course, if you have a cholestatic liver disease, you may have a high bilirubin, but the hepatocytes may be perfectly fine. So this is a less specific, less reliable marker. Hypoglycemia from glucose production tells you the liver is completely trashed. That's very late in the course, so it's not something that helps you out for most of the duration of this liver disease. Problems in urea synthesis and clearance can be reflected as a high blood ammonia, which can cause a mental confusion called hepatic encephalopathy, and Rich Mosley will talk about that tomorrow. This, again, is a late finding when the liver is not very functional, but it's very clinically important. These folks get very confused, and it really is telling you that this is getting toward a more terminal phase of their liver disease. How do you tell acute from chronic? Well, acute is a new liver disease, usually under 2 to 3 months. Many acute diseases, like the viral hepatitises, are self-resolving. Your immune system kicks into gear, it does what it's supposed to do, it eliminates the virus, you get over it, and it resolves, and the liver heals completely because you really have good capacity for hepatic regeneration. The definition of chronic liver disease, and this was just an arbitrary definition, we had to have one so that everybody's talking the same language, so it's a persistent liver disease that lasts more than 6 months. Occasionally, some viral hepatitises that do resolve just kind of hang on for a number of months. And you're spending your time reassuring the patient and saying, this will go away. Just be patient. By 6 months, it's chronic. And because there's ongoing injury, you may end up years later with a badly scarred liver, its complications, and hepatocellular carcinoma is one of those. So what are the clinical symptoms in acute hepatocellular disease? If it's a mild disease, they're completely asymptomatic. You may just pick this up as abnormal liver enzymes when you're doing a blood panel. Nonspecific symptoms when the liver is pretty inflamed are things like other acute illnesses. You can have a fever, although it's not a huge portion, nausea and vomiting, or loss of appetite, fatigue. Some of the ones that are more specific for liver would be jaundice, tender liver, this altered mental status, if it's really most of the liver is gone, unusual bleeding if the coagulation factors are way off. In acute viral hepatitis, these are a systemic viral infection, although the virus is really replicating in the liver. And because of the big immune response and inflammation, you can have some symptoms like headaches, myalgias, arthritis. There are rare cases where people will actually get skin rashes and urticaria and acute arthritis. And those are probably due to immune complexes circulating with the virus and the antibodies in the as the immune system is trying to clear the virus. So these are rare things with acute viral hepatitis, but they can occur. So what's the origin of the symptoms in patients who have acute hepatocellular disease? A lot of it, because many of these are viruses, and so they're inflammatory processes, is the release of inflammatory mediators, cytokines, tumor necrosis factor. That probably accounts for most of the nonspecific symptoms. If the liver is failing, and it's not making clotting factors, it's not getting rid of bilirubin, it's not getting rid of urea, then you get these more specific things. And then there's the immune complex mediated process that you can see. It's rare, but if you see somebody coming to the emergency room who's a little jaundiced and has been having some nausea and they've just broken out in urticaria, and you check their liver tests and their transaminases are 800, look for a viral hepatitis. Okay, so I did these drawings to try to indicate how you can get at least a crude sense of severity, how much liver has been destroyed. And it does sort of correlate with clinical symptoms in acute liver disease. If you have a mild liver disease where your transaminases are not all that high, not that much of the liver has been damaged, you're probably going to have, you are likely to be asymptomatic, and this may be only picked up if you're part of an epidemic that's being investigated, or family members gotten sick and you're being checked out, or something like that. In a moderate hepatitis, somebody gets some symptoms. These are going to be more the nonspecific ones, maybe a little jaundice, but the protime is normal. And you may have transaminases that are around the low thousands, high hundreds, low thousands. Fulminant liver failure, which means you had such a vigorous immune response that between your immune system and the virus, you've wiped out most of your liver. You will clearly have a lot of symptoms, and you will also start showing the signs of liver failure. And the transaminases may actually fall abruptly at some point because you've run out of hepatocytes. There aren't any more to necrose. Clearly, the life expectancy of this person is very short unless you transplant them. So asymptomatic, mildly symptomatic with some maybe jaundice but normal function, severe necrosis over a short period of time, symptomatic liver failure. Got to move fast on these. So fulminant liver failure is a very specific term, and it's defined as the onset of liver failure within 8 weeks after the onset of a new liver disease. And it's defined by impairment of liver function, increased protime, hypoglycemia, hepatic encephalopathy. You have to have lost more than 80% of your hepatocytes. Now, I talked to you about, when we were talking about malabsorption, I talked to you about pancreatic insufficiency. You had to lose more than 80% of the pancreas to be pancreatic insufficiency. That 80% is not an absolute number. You can't actually sit there and count the number of cells, so these are estimates. But that seems to be around the number. Many organs have a lot of reserve. And so to have absolute organ failure, you really have to have wiped out most of it. The mortality rate of fulminant hepatic failure is 40 to 80%. These are folks who are in the ICU. We're listing them for transplant. We're moving really fast. This is a high mortality disease. Otherwise, viral hepatitis is that you may feel miserable. You may feel miserable for a month or two, but it's not a fatal disease. So the approach to this is you identify it, you hospitalize, you consider liver transplant. So when you see someone with an acute new liver injury, these are the things you look for. Is there evidence of pending liver failure? If so, you do not send that patient home. Okay? So these are the things when we see somebody who comes in, they're jaundiced, they're not feeling well, their transaminases are elevated. You want to work them up and find a cause. You want to identify, is there a treatment? But you also want to say, is this somebody whose liver is going to fail in the near future? Because they are treated very differently. It's do not pass go, do not collect your ticket out of the ER. You've got the ticket for the inpatient ward in the ICU. And calling all your family and everybody else. Okay, where chronic liver diseases, by contrast, are usually diseases where the injury to the liver is more low grade, but it keeps going. Sometimes the Energizer Bunny is not a good thing. And so these patients often may not come to your attention until fairly late, because although they've got low-grade injury going on a day-to-day basis, it's not enough to destroy enough hepatocytes in a short period to cause them any symptoms. And so they may have very mild or even absent symptoms. Yes, the liver is trying to regenerate, but in the process of continued cycles of injury and repair, there's the trigger for fibrosis. And then at the end, when you have cirrhosis, you then get into the liver dysfunction. So what are the etiologies of hepatocellular disease? This is how I think about it. I try to think of it in categories. The first one is infectious. Those are the viral hepatitises. There aren't really bacteria or parasites that do much in this type in the liver. If you go to Mexico, you get amoebic dysentery, the amoeba can get to the liver, you can get a big abscess. It's not a hepatitis. It's a big ball, and the rest of the liver is just fine. Again, you may be pretty sick, but it's not a hepatitis. Then I think of non-infectious inflammatory. And I remember there is always an autoimmune disease. No matter what organ you're talking about, there is an autoimmune disease. So there's autoimmune hepatitis. There's drugs and toxins. Because the liver metabolizes a lot of drugs and xenobiotics, it can sometimes generate toxic metabolites, and so there's drug-induced liver disease. Alcohol is probably the most common one, but there are others, and we'll talk about that next week. There's always genetic diseases. The three big ones that cause chronic liver disease is iron overload from genetic hemochromatosis. We'll talk about that. Wilson's disease from copper overload, and alpha-1 antitrypsin, which I talked to you about yesterday. There are metabolic diseases. This is becoming epidemic in the United States with our increasingly obese population. Insulin resistance is going up. We're getting non-alcoholic fatty liver disease. Hyperthyroidism can cause some abnormal liver tests. It's not a big player, but it's something to think about. You then have vascular. Every organ is vascularized. There's got to be something that can go wrong with the blood vessels. We talked about outflow obstruction or heart failure causing congestion in the liver, which can lead to damage. Decreased perfusion with shock liver, that's an acute process, actually hyperacute. If you block the sinusoids in the liver, if you block the areas right around that can get ischemic. So you can get a patchy ischemia. Sickle cell was probably one of the first there. There are hepatic crises in sickle cell. Now, that's a patchy because it's whatever sinusoids got blocked, and so you may still have a lot of liver cells that are doing fine. You can have infiltrating processes, things that move to the liver and grow, and they more push things aside. So tumors, amyloidosis, and granulomas. And patients who have chronic bowel inflammation can have abnormal liver tests. They can have mildly elevated transaminases. We think it's because more bacteria, tumor necrosis factor, lipopolysaccharide things are coming up the portal tract. This does not cause cirrhosis. It does not cause a serious liver disease, but you will be asked sometimes, you'll be working up somebody with Crohn's and somebody says, oh, their AST and their ALT are slightly elevated. And this can be the cause. You have to look for the other things because people can have two diseases, but we do see that. But that's not a serious liver disease. It doesn't cause any problems. So the diseases we're going to cover today are viruses, autoimmune hepatitis, and the fatty liver diseases. Others we're going to cover in later lectures. I'm going to talk to you about the cholestatic diseases tomorrow. So viral hepatitis is the most common form of acute hepatocellular disease, both worldwide and in the United States. It's also the most common form of chronic hepatocellular disease worldwide, and Analog is going to give you more details on that. Today, we're going to talk about the how to identify a virus, because this gets a little complicated. And so, I've also got cases in your handout for you to think through about how do you interpret the virus serology test. How do we identify viruses? And I can tell you that when you're on the wards and seeing patients, you're going to have to check boxes on an order sheet. So you need to know, if I want to look for this virus for acute or chronic, what test do I order? So case history, just an example, 30-year-old woman with 1 week history of increased fatigue, nausea, loss of taste for meat and oily foods, a couple of days of dark urine. She notices yellow eyes in the mirror and decides she better come in and be seen. Physical exam, she clearly is jaundiced. She has a moderately tender liver. And when you look at her lab tests, her blood counts are normal. Her bilirubin is clearly elevated. And I'll tell you that's basically conjugated. But her transaminases are elevated close to 1,000. Her alkaline phosphatase is mildly elevated. Her albumin is normal, and her prothrombin time is normal. So is this hepatocellular or cholestatic? Yeah. Her transaminases are far more elevated related to the upper limit of normal than her alkaline phosphatase is. Is her liver functioning? Yes. Now, she has an acute disease, so the pro-time is going to be the better marker here, but it's completely normal. All right. So if you biopsied her, this is a normal liver. You've got a nice portal tract here with the portal vein. You've got some bile ducts there. There's a hepatic artery. You've got a central vein over here. These are the zones. These are not bacteria. 1, 2, and 3 is the zones. And you've got some red cells in the sinusoids. This is an inflamed, injured liver in somebody with an acute viral hepatitis. So you see some liver cells, but you see thousands of little blue nuclei, which turn out to be lymphocytes, and occasionally you'll see one of these apoptotic dead liver cells. So this is what her liver would probably look like. And you have a young adult with an acute hepatocellular disease. Viral hepatitis would be a very common cause of this. So then you have to find out how you're going to figure it out. So to test for viruses, you've got a number of options. You can do antibodies to the viral proteins. They're usually to the coat proteins. And this is where you need to know IgM versus IgG. Did they talk about that in infectious disease last year? Okay. The first response is an IgM. IgG is a later long-term response. Think of it that way. So if you're looking for what acute illness does somebody have right now, you want the IgM antibody. If you're looking to see were they exposed in the past or do they have a chronic infection, IgG. Viral proteins in the blood, we really usually can't measure. The number is small. I'm going to show you the exception is Hepatitis B. It's a bizarre virus. It makes enormous excess of one of its coat proteins, and there's so much in blood that it's actually easy to detect. But that's unique for that virus. So the other thing, of course, with the development of molecular biology is we can look at nucleic acids. And probably most infections in the future are going to be more and more this way. So if the virus is in the blood, you can then detect its nucleic acid. And the labs now can do many of these with a fairly rapid turnaround. So I'm going to talk, there are 5 major viral hepatitises that we're going to go through here in terms of serology. Hepatitis A and E are fecal oral transmitted. They actually are excreted in the gut, so there's not a lot of virus in the blood. B and C and D have a lot of virus in the blood, and they are more sexually blood transmitted, things like that. B and C and D can also become chronic, whereas A and E don't. Now there's one caveat. In France, liver transplant patients have been identified, immunosuppressed patients have been identified who got hepatitis E and couldn't get rid of it. But otherwise, we say you never get a chronic disease from A and E. B, C, and D, you can get chronic disease. So they are the sources of the chronic liver disease in the world. It's due to viruses. D is a parasite on B. So to get D, you have to also have B. And we don't have much D in this country. It's very rare. So B and C are the major ones. We thought there was a G at one point, but it turned out it wasn't. So this is what we've got. So the alphabet of viruses is A accounts for about 30% of acute hepatitis in the United States. It never causes chronic disease. There's a prize among hepatologists for who first identifies a chronic hepatitis A patient. It's never been claimed. B is about 30% of acute hepatitis, accounts for about 15% of chronic hepatitis. C is fairly common, but you don't get sick usually when you get it, so it's rarely detected at the acute state. It accounts for the bulk of the chronic viral hepatitis in this country. D here is very rare. E, we're starting to think it may be more common than this, so we do have to think about it with acute hepatitis. Except in rare immunosuppressed patients, it doesn't cause chronic disease. There may well be other viruses, but so far nobody's found one. So I'm going to first talk about the 2 that are fecal oral transmitted and are acute viruses that resolve, and that's A and E. And this is just a simple, these are simple RNA-based viruses. They have a capsid protein, and they have the RNA. Because these are fecal oral transmitted, the virus is excreted in stool. There's very little in blood. So outside of a research lab, we don't have tests for the RNA. So therefore, what is your way of detecting acute hepatitis A? The IgM antibody. Okay, so this is your hepatitis A virus. Nice little virion. It's got its RNA in the middle. It's got its protein on the outside. So what you can ask the lab to do is measure for IgM antibody, which of course is forming immune complexes with the virus also. So you want the IgM. Now, with time, as this resolves, the virus goes away, the IgM antibody goes away, and what you're left with is the IgG antibody. So if you want to know, is the virus present, is this an acute infection, you want the IgM antibody. If you want to know, did this person get exposed to the virus in the past, you want the IgG antibody. Okay? Hepatitis E is identical. We've got the virus. If you want to know, is this an acute infection, you want the IgM antibody. If you want to know, is the virus, was this person ever exposed in the past, then you want the IgG antibody. Okay? So these are simple. There's only one test in 2 flavors. So think of it as IgM acute, IgG past exposure resolving. Okay? So the IgG is actually a great test for doing epidemiology and saying how many people in a population ever saw this virus in their lifetime. Okay? Now, So that's A. And as I said, they are fecally orally transmitted. Virus comes in the mouth, goes up into the liver, replicates, goes back out in the bile, into the bowel, and very little's in blood. So that's why an RNA test was never developed. Now you ask, why not do RNA on the stool? People don't like handling stool. And the viremia for these is very short. So what are the risk factors for getting this virus? Travel. So contaminated food and water. And so that's why all the restaurants in the United States have big signs in the bathroom saying all employees must wash their hands before they go back to work. Because these are fecal oral. And when you see those stories about an outbreak of viral hepatitis related to a restaurant, it's A or E, and it's primarily A. And it's some worker was sick. They might have even had a mild case and didn't know it. And they contaminated the food or the water, and people got sick. And that's why travel is a risk, because some other countries have not quite the same standard of sanitation we have. Now, that may save them some other things, but that's it. Okay. So hepatitis A, it's a very transient viremia. By the time that you see the patient and they're sick, there's virus in the feces, but not really in the blood. But they have the IgM antibody that disappears, and you get a long-term IgG, which is also protective, so you won't get this again. There's now an excellent vaccine as well. Hepatitis E is also an RNA virus. We're thinking there's a form of it that may actually be more common, but it behaves like hepatitis A. So the more virulent form is primarily in a big swath along Asia, part of Africa, but actually there's a different strain that may be more common in pigs in much of the world, and it is possible to get that in the United States. So if you're seeing a patient in Michigan and the hepatitis E IgM antibody comes back positive, you say, congratulations, you have acute hepatitis E. What other questions should you ask them? Where have you been recently? And do you work with pigs? Are you a pig farmer? Yeah, where have you been? Okay, so E, it's the same thing about the IgM versus IgG. There is a vaccine that's been developed. It's not commercially available, in part because the use of it in developed countries that have a lot of money is not very high, but it may eventually be licensed. So viruses that can cause both acute and chronic disease are the other three, the B, C, and the D. Now, hepatitis B is the one I'm going to spend the most amount of time on because we have a lot of tests for it, and it gets confusing. It's also a very strange virus. So it is a DNA virus, but it replicates through an RNA intermediate. So it is a retrovirus. And that's the only thing it shares with HIV. But it turns out some of the drugs we use for HIV actually treat hepatitis B, because this thing has to have an RNA to DNA polymerase to get replicated, okay? It is blood-borne, sexually transmitted also. A ton of serologic tests have been developed over the years, which leads to information overload for all of you. And we will try our best to work your way through it. So this is a complicated virus. It's got a surface coat. It's got a nucleocapsid with core proteins that also bind to its partially double-stranded DNA. So the coat protein is called surface antigen. And that one's important. That's the one that's produced in large amounts that we can actually measure in blood. There is a core protein which we can measure an antibody to. And there's the DNA. So there's at least three things we can measure. We can measure the surface coat protein. We can measure this core antigen, or at least an immune response to it. We can measure the DNA. All right. There is a DNA polymerase. That's a research test. There's also an E antigen that we can measure, which is a version of the core protein. You can have antibodies to all of those. So you can measure viral DNA. You can measure surface antigen. You can measure E antigen. You can measure antibody to the surface protein, antibody to the core protein, antibody to the E protein. So that's 6 tests. Okay. Now, the surface antigen is what makes this virus really unique, and this is actually the first marker. The guy who identified it, Baruch Blumberg, got a Nobel Prize for that. It was an incidental finding because he was doing serologies of different serum proteins, and the original name was the Australia antigen because he picked it up in blood from an Australia aborigine. But the reason we can measure the protein in blood is this virus makes a mistake. It makes tons of surface coat protein, astronomical levels, orders of magnitude more than it needs to make its viruses. And so this extra surface protein is shipped out into the blood, and it appears in blood in little spheres and linear rods that is pure surface protein. There's so much protein there, it's easy to detect. Okay, now the next protein that we have to talk about is core antigen. This is the core protein. It interacts with the DNA. It can't be measured in blood because it's buried inside the virus and there's no excess. But this is the one where you can get a nice IgM or IgG antibody. So you can have an IgM form that tells you acute, IgG, which says it's no longer acute, past exposure. Right? So the IgM thing that you can do here is to the core protein. It just happens that's the most reliable of all of them. Now we have another protein, E antigen. It's an alternately spliced product of the core gene, and I'll show you a picture of that. It's also made in excess when the liver is producing a ton of virus. And it can be measured, and there's an antibody to it. But there's no IgM form. They just made life was complicated enough. So this is how the core and the E are related. So in the hepatitis B genome, there is a core protein, which DNA and RNA, which is this whole piece. There's a signal sequence, there's a central portion, and there's a DNA binding region because this core protein binds to the DNA. So when it's synthesized and you make core protein, it's the purple and the red. That's the functional core protein. It binds to the DNA, forms the nucleocapsid, and things go very smoothly. However, there is an alternatively spliced version, which is just the purple part. Again, it's a mistake as far as we can tell. That part will go to the ER because it's got a signal sequence, and it gets transcribed, but it doesn't have the DNA binding region. So it's floating loose in the ER, and it gets shipped out by exocytosis with everything else. And so this is the E protein. It's a shortened version of the core protein. So when you have acute hepatitis B, you get a viremia, and that viremia actually persists. So by the time somebody comes in to see you, they may still have virus in their blood. They're certainly going to have this surface antigen because they're making a lot of it. And they may have E antigens still present. E antigens here, although E antigen disappears. So about the time they come in with their clinical symptoms, the disease is very well established. They may well still have virus in their blood. They've probably, if they're in here, have surface antigen because it hasn't disappeared yet. The E antigen may well have disappeared by then because the disease is resolving. The transaminases are elevated, and you have the IgM core antibody. So when a patient comes in with acute hepatitis B, surface antigen, DNA may still be positive. The IgM core antibody is positive. That's how you make the diagnosis of acute hepatitis B. You've got surface antigen, says the virus is there. You've got core IgM antibody. Now, as it resolves, you switch over to just antibodies, and you switch to an IgG core. So somebody who had hepatitis B in the past, like 3 years ago, is going to have an IgG core antibody, probably an E antibody, and they'll certainly have an antibody to the surface protein. And it's the surface protein antibody that is protective. And I think all of you have probably had the hepatitis B vaccine. Okay, it is purified surface antigen. There's no virus there. This is molecular biology produced in E. coli cells. It's pure surface antigen. So if I checked your blood, which of these antibodies would be there? Just the B surface antibody. The other two would not be there because you haven't seen them, unless you happen to have actually seen the virus as well. Okay. Once the virus is gone, then you have these antibodies left. Now, many years afterwards, the titers may fall. They may not be that apparent, but they're there. You can get hepatitis B that becomes chronic. In that case, you still have the virus, you still have surface antigen, but now you've got IgG antibodies. And if you measure DNA, you can usually measure DNA in blood. So a chronic disease is the virus is there, so you have surface antigen, you have antibody, IgG antibody to core, you may later on have an antibody to E, and you've got the DNA. In the chronic cases, this is where the twist comes with the E protein. And I wish we could just get rid of E because it now confuses everybody. But the E protein in chronic B is there at the beginning, but at some point along the line, it kind of disappears and you get an E antibody. Now, that actually doesn't tell us that much, but the tests are there. They're on the lab slip, so I need to explain it. And it has to do with how fast the virus is replicating. If the virus is replicating like crazy and you're making a lot of virus, then you have the E protein in the blood. If the virus is not replicating very fast, and lower amounts of virus are in the blood, there's not very much E protein made, and now you can see the E antibody. Because what you're seeing in blood is which one is prominent, the antigen or the antibody. Because antibody will bind the antigen and try to get rid of it. If you're in massive antigen excess, that's what you can measure in blood. If you have very little protein antigen circulating, then you'll see the antibody. Okay? So this is a cartoon that shows when there's a lot of virus being made, and this is the full virion. You'll see the virus in blood. You can measure the DNA. You'll see surface antigen. You'll see E antigen. When you have a small amount of virus being made, you can still measure the surface antigen. You can still measure the DNA, and you can actually calculate how many viral particles, but there's no more detectable E protein. So now the E antibody is positive. Okay, so let me show you some of my attempt to make this all clear. So this is the hepatitis B virus. And it all got caught up. There you go. All right. So what we have is 3 layers. You've got the outer coat protein, which is surface antigen. You have the core protein in here, which is core, and a misspliced part of it is released as E. and you have the partially double-stranded DNA. Okay. So what do you have in blood? It depends. Okay. So this is your surface antigen. So you've got the whole virus. So with acute hepatitis B, you've got the whole virus. You have the excess surface protein being released into blood. Okay? In an acute disease, at the beginning, you're making a ton of virus. So you also have all this excess E protein running around in the bloodstream as well. And you're making the IgM core antibody. Okay. So you can measure the viral DNA and particles in the blood. You can measure the surface protein. You can measure E protein, probably. And the helpful diagnostic one is the IgM antibody to core. That's acute hepatitis B. As the infection resolves, the core protein disappears because you're not making much virus. And you still have the virus, the surface antigen, and the IgM protein. Now, if this completely resolves, the virus disappears, the surface protein disappears, and you now convert to the IgG core antibody. And with time, you will get antibody to the surface protein. And it's the surface protein antibody that's your protective antibody, so you don't ever get this again. So when you're completely resolved, virus is gone, you have two antibodies that you can measure that are helpful. I'm ignoring the E antibody because it really doesn't help. You've got the IgG core, you've got what's an IgG antibody, the antibody to surface protein. That's resolved. Now, somebody who gets acute hepatitis B and it becomes chronic, the virus continues to be produced at different levels. You always have the surface antigen. But you can tell, so if you see somebody and they've got virus in their blood and they've got surface antigen, your question is this acute or chronic? So look at the core antibody, because you will now have the IgG core. So virus, surface antigen, and IgG core says you've got a chronic disease. So it's really the IgM, IgG core that helps you the most in saying, when you see a patient for the first time, is this acute B, is it chronic B? Now, in the chronic situation, where you've got virus, surface antigen, IgG core, you may have lots of virus being made. In that case, you've got E protein. You may have a situation where very little virus is being made. In that case, you've got E antibody. It's all chronic disease. Okay. We're going to have to work through some of these also, because I know this gets very complicated. So, in essence, you can look through these and say, how would I interpret different combinations? And I've got some practice cases in your handout for that. And I'm just putting those in to remind you of what these various abbreviations mean. Delta virus, can only get it if you already have B. It uses the surface protein as its own viral coat. You can measure an IgM antibody in research labs, and if you talk to the CDC, you can get an RNA. This is vanishingly rare here, but if you have somebody with chronic B and you're concerned they might have D, you can send off the antibody. It's an IgG. And you can also get chronic D on top of chronic B, and that gets really complicated. So the last one I'm going to show you is hepatitis C. It's the most common cause of chronic hepatitis worldwide, and it's one of the most common reasons we have for transplant. So the hepatitis C virus, there is an RNA, and there's coat proteins to which we have an antibody. This one got discovered after molecular biology had been invented. So actually one of the first tests, aside from an antibody, was the RNA, and that's what we use. So there is no IgM, and the reason is most people with acute C are asymptomatic. We never find them, so there's no use for the IgM. But you do get an IgG antibody that develops later on. And we always have the PCR available. So you've got the virus, and you have an antibody to it. And that's what we have. So you can measure RNA, you can measure an antibody. So therefore, when somebody gets this virus, the RNA appears in blood. When they get an acute case, the only marker is going to be your RNA, because we do not have an IgM antibody. I mean, the body makes one, but we don't have a test for it. Let's put it that way. Our laboratory does not have an IgM antibody. As you develop chronic disease, you continue to have RNA, but you then have an antibody that shows up. So in acute disease, the only marker is the RNA. In chronic disease, you should have RNA and you should have antibody. If you resolve your hepatitis C, what would you have in your blood? Antibody. Okay? So for acute hepatitis C, if you want to know if somebody's having acute hepatitis C, ask for the RNA and the antibody. It should be RNA positive, antibody negative. If you're looking for chronic hepatitis C, RNA's positive, antibodies positive. If you want to find whether somebody had the virus in the past but got rid of it, because some people do, the RNA's negative, the antibody's positive. Okay? Yeah.
You just had an acute case and it resolved. Would you have the antibody?
Yeah, because the virus is around long enough to tell your immune system to make an antibody. And that antibody can last for a long time. Okay. So other hepatitises absolutely exist. We don't know about them yet. So this is to remind you of the serologic diagnosis for acute viral hepatitis. This is for chronic. So this is how you tell the difference between acute and chronic. So I was just going to mention quickly autoimmune hepatitis, because this is inflammatory, but it's not a virus. It's an autoimmune disease with T cells and plasma cells leading eventually to chronic disease. There are some antibodies that are characteristic. They're not absolutely diagnostic, but you look for anti-nuclear antibody and anti-smooth muscle. And you usually have a lot of polyclonal immunoglobulin. You've got a lot of activated plasma cells here. And we can treat it, and we can suppress it. We cannot cure it, but we can treat it with fairly mild immunosuppressive drugs. What's in here are tons of plasma cells infiltrating out into and around liver cells. So the biopsy is different in some ways than a viral hepatitis. Fatty liver diseases, we've talked about. Alcohol can do it, and fatty liver from insulin resistance. And there's a fatty liver picture. The pathophysiologies of these are very similar because they start with lots of triglyceride. In each case, some patients can develop a fatty liver hepatitis, where you get damage to hepatocytes, swelling, inflammation, and eventually they can develop fibrosis and cirrhosis. So we have alcoholic liver disease. We have non-alcoholic fatty liver disease. Development of the fatty liver is a little bit different depending on how the fat gets there, but the ultimate picture is very, very similar. And something else happens in some of these patients to trigger that inflammation fibrosis pathway, and we haven't figured out what that is yet. Lots of suggestions. Oxidative stress is always a popular one. So in summary, many diseases cause hepatocellular injury. The lab tests can indicate that there is a hepatocellular disease. They can tell you the function, and then they give you some clues as to acute or chronic. Then you need to do very specific lab tests and or take a history to figure out the disease. So a lot of this was on the viral serologies, and we'll go over that in some of the problem sessions, and you've got examples of that. The autoimmune hepatitis is these two antibodies. Fatty liver is a history and a biopsy. So we'll take a break, and then we'll get back to pathology of liver disease.